Health World. Today we have with us Dr. Sudhir Rawal, Director, Surgical Oncology and Chief of Urogenital Services, Rajiv Gandhi Cancer Institute, New Delhi. He has to his credit over 1,000 robotic cancer surgeries in his field in the last 4 years. He is the first surgeon to do so in Euro-Asia region. Now over to Dr. Rawal.
Hello. Okay. So I have to go for PP. Where is my PP?
You will start. We'll take it. I can see it.
Okay. How do I do it? You can see my PP?
Yeah.
Okay. Delay. I don't see this. Yeah. Okay. I'm starting this presentation today's afternoon, and I thank everybody who has joined me on this web conference. This basically is to go through my experiences of robotic surgery and what actually is robot is. So my presentation will be like what is robot and the history of medical robot, because many of you may not be doctors or who are the doctors who wants to become robotic surgeon, or maybe some other non surgeons, or maybe physician, mixed crowd. And that is basics and what robotic surgery is about, especially in robotics. This will be what are the development in the robotic surgery. So this is how my presentation will go. Last decade, if you see, had been very exciting in the technological revolution. World over, there has been a lot of innovation in nanotechnology, cloning we have seen from Dolly to other things, and then you have genomic mapping, you have human genome coding and decode. These papers are commitment. The last decade's invention in the surgical field, and this has rather started with the laparoscopic surgery and then robotic surgery. Then you have seen that genetics are available in the main events. The robot, what is robot? Is a machine that resembles a human or does mechanical routine task on command. It may not be like human, but it can be like human. But it does task and command task on the command of anybody, of human. It doesn't work on its own mechanical device skill. A robot is not a machine, it is an information system with arms. So it's like you put the information, it will work, otherwise it will not work. Leonardo da Vinci, famous painter and inventor, was the robot-like thing in 1495, and he showed that there's the armored knight for the purpose of entering the royalty. He entered as a knight in the royalty. This is the past robot, which you have seen on the left side. Then there is a present robot in most of the uh, this is like enhanced, not possible. Nowadays, invasive surgery, if you did as a standard of in the hospital, and patients are, so this is what led in the with the open incision, the patient said long back that is a big problem. It's the bioages to the surgeon's dexterity. These movements and a movement, because use just the two dimension is in your brain, so it slows the movement. There is a disorientation, they call it restricted degree of freedom. They do not move in all the direction. Then the resting tremor, if you move less on your side where the hand is, that gets amplified at the tip of the instrument, and then there is chances of injury or chances of taking instrument somewhere else rather than to the operation site. And the ergonomically inefficient, surgeons get tired like anything, especially in the bigger surgery, and it's an uncomfortable position for the surgeon. That is why there's a lot of innovation came to overcome these problems. But later on, the robot actually had taken over all of these problems. So this is a barrier for novice laparoscopists. The learning laparoscopy causes it takes a lot of time, a lot of effort, and many of them may not learn even the many robotic surgery is not a transition from laparoscopy to the robotic surgery. It's a fulfillment. When you go on the robot, you do laparoscopy, but it is through robot. So that's what the advantage of robot is. This is how you compare with the robotic and laparoscopy. Like finger, hand, and wrist are used in the robot. You use your finger to cut, hand to as a wrist, and hand to catch or anything, and the wrist to movement and to move. And this is more precise dexterous position rather than when you use laparoscopy. Then you see there is a wrist, forearm, and shoulder which moves. This is a less precise. That is why the robots take over the laparoscopy. I'll be showing in my video also. Now the types of robots pull and then hold. They just hold these robots came in the beginning, and many surgeons in the laparoscopy they use them. They do hybrid surgery, like for the camera they will use the robotic arm, and rest of the thing they will do laparoscopy. And there's active robot. There's a robot would actually do the surgery, so on the surgeon's command. So these are the early surgical robots, like Minerva was used in neurosurgery, then the Probot. This was the first robot used in urology, where the TURP was done in 1984. Then Robodoc was used for hip replacement, but they did not become popular. The popular robot which actually came in 2000 when the Defense Advanced Research Project Agency, DRPA in America for military research, was actually trying to do remote surgery in the battlefield, and they actually did cholecystectomy via telesurgery almost 300 miles away. And the Intuitive created in 99 after acquiring the patents for military, and this was the first robotic radical prostatectomy was performed in 2001 from the Da Vinci by an Indian surgeon. You can go on net you can find about him. He is Dr. Mani Menon. And after that is there is a huge exponential use of a robot in all the surgical field, not only in the urology, but the robot in the beginning came for to do the cardiac bypass surgery. At one point of time in 90s or 80s, CABG was most common surgery in America, and cardiac surgeons were very busy all over the world, till the cardiologists made them almost their work. They took their work almost 80%. So these surgeons, these engineers, those who made this Da Vinci robot, they asked the cardiac surgeon to use this machine. However, this was not picked up by them, and by serendipity, it landed in a hand of urologists, because urologists were doing radical prostatectomy. Open radical prostatectomy was also is a cumbersome surgery, and same thing was for the laparoscopy, was more cumbersome, and not many surgeons all over the world could pick up this surgery with the laparoscope. That at one point of time, when you go to these international conferences, there were only 3 surgeons, 2 in America, 1 in France, who were doing laparoscopic radical prostatectomy. Rest of the world was struggling to do this surgery by laparoscope. And this actually led to one surgeon, Dr. Mani Menon, to use the robot in his radical prostatectomy operation. And that actually was so easy, and it became popular all over the world, that now in America you don't see surgeon doing open or laparoscopic radical prostatectomy. Now it is almost 15 years for the 14 years for that event, but this has happened a few years back, that there will be very few centers in America who will be doing open surgery, but most of the radical prostatectomy now in America done by robotically, almost 98%. Now, what is a Da Vinci telescopic surgical system is? This is robotic cart. I'll be showing. Then there is a console. This has a 3 component: robotic cart, console, and the endoscopic stick, endovision cart. It's a high quality magnified surgeon controlled 3D image. When you sit on the robot, you see 3D high quality image. This is what the robotic cart is. This goes to the patient. This is a forearm and arm, but later on they have evolved to forearm. There is another sleeve. This machine is but it is surgeon set, which is 3. It's a 10 when you have the instrument and control panels and foot control. I'll be showing in the next image. Yeah, in another next slide you can see that console also is the actually what the joysticks and the foot pedal on the console are. These are the instruments which are used to operate on the patient. The lower downs are the diathermy pedal. There is a camera clutch where you can see the camera is made, and there's no on the left side there is a change to this is the remote control. Actually, that you operate, and they are and that this door movement you will see in my to train your juniors or maybe new surgeon when you have the faculty or the residents coming. So how to train them? We use simulation. There's a simulator machine which is now part of the robot is the what operate these and to actually standing out the end of emerge because of his race magnification. See on my computer, you may not be machine which can be used. Just want to operate on the tumor is and take some of the kidney with that. There you use this machine where you can, and this works with the robot whenever you want, but this works beautifully with the robotic machine. These are the endorphins which I was talking about here. There's a tremor negative. The tremors, they get filtrated when you move your hand outside the body, so there is no tremor inside the body. The fine movement where you move 1.5, the movement in the body will be only once, so this becomes safer. It has got a position sensing of 50 times per second. There is at the tip, there is 6 degrees of freedom of movement, but then the 7th degree of freedom movement is instrument itself, which goes up and inside and out. That's the advantage of the movement. I'll be showing this video. I hope it works. Do I play? No. I'll go back. Okay. And now it will play. This is
Tremor,
how the
there is no tremor as you see
what exercise it opens without any problem. There is no tremor as a lot of problems and the robot. Then there is your as a field of operation intra-abdominal artery for correcting, which is not there with the laparoscopy. Before, depending on there is a less pain, patient will be cutting the maker in season. Almost all of the life, it actually lot of causes a lot of pain, and if you present it hyperprostectomy, which meter, then in a journal so less that its recovery improves. Like then there is a less infection because you are in a closed environment. It's open like in open surgery. You don't it reduces the chances of infection. The less blood loss and transfusion. This is phenomenon when you have blood loss. The surgery which I was at me, the patient's blood loss is 100 to 200 times less than 100. 100 and reason. We have done our surgery. Keloid, the scar which actually looks very bad, especially in the female. If they develop scarring, they really, they are upset with their body habitus and they feel depressed. So this thing is not there. Then the faster recovery, because blood loss is less pain, they start eating fast and they go home early and they quick and this leads to quicker return to the normal activity. Now there are some disadvantages of robot. It's not like there is win-win situation, and it has been criticized for lack of tactile feedback, and this actually can be over. This gets overcome by by another feature of robot, which I'll be talking about later on. Then the bulky robotic arms, they can collide, which I told you with the SI, the previous robot. There's the problem, but the new robot XI, it's not a problem at all. And then the cumbersome setup. In beginning, you do feel that you have to bring whole of the machine to the patient, and then you have you have to dock with the patient, and that takes time. Especially in the beginning, it takes around half an hour, but later on, you become used to and you are faster. Inability to move surgical table once the robot arms is one of the big. When you have fixed to the table, you can't to give some angle. And you have to check robotic surgery. You have to, but places where you don't know, most of the places you don't need this, but wherever you need, you have to. It is expensive machine. Dollar machine. The new ladies who are postmenopausal, and when you operate them with the laparoscope, it's a huge problem. Many times they get end up with the open surgery, but with the robot, you can easily overcome this obesity and operate these patients with the equal cancer control as with the open surgery. When you compare, there I'm not talking about. I'll not be showing any comparable result of open or laparoscopy or robotic which is academic point of view, but there are innumerable articles that you require a motivated, hard-working team with passion to do these surgery. I have a big team in my hospital who work with me, and they are very well trained, and they are learning robotic. Many of them, they are very good in robotics, and they are picking up very fast. So we acquired this robot in 2011, and I did my first radical prostatectomy, that robotic surgery, in 28 February 2011. And since then, I have used this robot for all the uro-oncology surgery, the cancer of the urology, and gyne-oncology surgery. And some of the unusual tumor I have removed from the pelvis, like angiomyxoma, which were these were young ladies who came to me with a huge tumor, but which is peculiarly, you can't feel it, but it's a really problem for an unmarried or married girl who's young. So we use robot to operate these patients. We did this number in 4 years and 2 months, and we have now come, I think we are completing more than 1100 surgery. Number includes most of the complex surgery. These are not the surgery which are simple, like removing gallbladder is not a surgery with the, to do with the robot. Laparoscopy is equally good. But if you do laparoscopy for prostate and bladder, then you will have huge, you have to put a huge effort to do this surgery, and at the end of the day, you may be thinking that you are not justifying to do laparoscopy for such surgery. So these are very complex surgery which have been done by robot, and we use in only in the cancer patient. We have no patients who come for non-cancer and to get operated. So we always use in a cancerous patient only. This is the peculiar situation in country we had for last 4 years. These are the numbers, as I told you, with the year-wise, 2011, 12, 13, urology we have done 534, and gynae surgery we have done 393. We have head neck unit which has done 139, thoracic 48, RPLND. This is the very complex operation which I do in our hospital. We have used in 27 patients, and there is a video endoscopic inguinal block dissection. We have operated 47. So it makes around more than 1100 surgery. However, it must be more. We have not updated these data. This is a video which I'll be showing to you guys, and I may stop in this video in between in interest of time. This is the radical prostatectomy, and this is how the patient is positioned in the OR, and I'll just show you how we use these instruments. This is the bladder retracted up, and I'm cutting the peritoneum between the bladder and the rectum. Those who are doctor among you, they will understand. This is the vas deferens which I cut, and now I am releasing the seminal vesicle. I'll do it on both sides, then proceed to drop the bladder. Those who are not doctor or who are doing their who are in medical school or who are engineer, for them, on my right side is the hot shear. This is the scissor which uses monopolar diathermy. In my left hand, I have two instruments actually. This is the bipolar forceps, and the thing which was retracting the bladder, now it has again retracted the bladder on the left side, is the progress forceps. And this is to retract the bladder, and this is how you make a plane between when the paravesicle is spaced, and the bladder will be dropped down after cutting the peritoneum and dissecting this avascular plane. This is how we are cutting medial umbilical ligament, and the bladder will be coming down now. And once the bladder is down, you cut the endopelvic fascia. This is the endopelvic fascia. On both sides you cut. There's the levator muscle on which the prostate and bladder they rests. And on the left side, this is another endopelvic fascia. I'm taking DVC. This is a dorsal venous complex. It causes a huge bleeding when you take or during your initial career of learning radical prostatectomy, because I learned radical prostatectomy on my own by reading through the books and changing the approach most of the time before I landed up in a standard approach which I do now, and I teach my juniors every 6 months. We have this workshop to do the open surgery, because not everybody can afford this machine. So a lot of young urologists, they come to our institute and they want to learn open radical prostatectomy. But with the robot, you can see how easy it was to take that suture, and it is because the technology which I told you with the endo rest, with a small instrument which you can move in that small space. You can't move your hand in that small space. I'm going behind the bladder now and will be catching the seminal vesicle again. These are the one which I dissected before, and now they have come here. So this is how the prostate is now being removed by taking the lateral pedicles. These are the energy sources which are used. You can use clips also. You can use energy sources also, which your assistant is using. The machine is so safe that any type of bleeding you can sort out with the robot, especially in the experienced hand, but also in the beginning when you start learning the surgery. It's not a big problem when you do these complex surgery with the robot. So I'm now detaching the prostate. Just will be taking out the prostate in a few minutes, and later on we'll be suturing the bladder to the urethra. This is how the prostate getting defined. Now the clip is coming. This is to actually drop the neurovascular bundle, which are responsible for the continence of the urine and erection, which are two complications. When we talk to the patient, we say that you need to understand that you may be incontinent in the beginning of your recovery, and you may be impotent either permanently or maybe temporarily. These things, and we do save the nerves depending on the disease. If it is early disease, we save the nerve. If it is advanced, locally advanced, or in a later stage, we cut those nerves. This is how the prostate is mobilized completely, and then we go to the anteriorly. We'll be detaching the prostate off the urethra. Once this is done, bladder will be joined back to the urethra again. No. Shall I go ahead with the meditation? 5 minutes. Okay, I have 5 minutes more, so I'll go to my next slide so that I can. Now the arguments against robotic. This is interesting. Cost. Then why to operate by machine while you can do the same job with your hand? There is no haptic feedback. Haptic is touch sensation. You don't feel anything, and it may not be safe with the complication. Suppose you injure the vein or artery, then what will happen? I will take them one by one. The cost, $2 million machine, then maybe more. Then it has a maintenance cost of $120,000 per year. Then cost of the instrument, each instrument is $2,000, and minimum you have to use 4 instruments at least, 4. Sometime maybe more, but I use 4 instruments in most of my surgery. These are the instruments which I've shown you, and because you can use one instrument only in 10 patients, so 10 use per instrument. Thus disposable charges to the one per patient comes around 60,000, and around 1 lakh per patient. Then this is what the cost is. So are we justified in using this technology in India? And what are the factors which help to the patients, related society, and the hospital also? What will happen to the hospital? Does it go in the loss, or it gains, or what happens? uh, cost. The patient has less pain. This is the patient factor. He has less pain, early recovery, less blood loss, early back to home, and in some situation he goes to the work. Especially suppose you have removed a small tumor in a adrenal, or you have done the paraganglioma. You remove it up maybe in 10 days or 12 days or 2 weeks. He goes home. He starts working. So you save money. He saves money there. Relative and society. Since the patient stays for less time, everybody around him, friends, relatives, they are free early, they can go to the work and they help the society, whatever the work are there. So you know, work hours, they don't get lost. And this is how everybody gets benefited. And the hospital also gets benefited with robot by one is, which is big, very good, great, big thing in most of the hospital in India and America is brand value. If you have a robot, you know, you can say that this hospital is one can rely on. The lesser stay, you effectively have more beds, and then you can make more money. Anyway, you are charging hospital charges 1 lakh almost to the patient, more to the patient, and that is how the hospital recovers the money. Then second argument is why to operate with a robot when you can do the same job with your hand. I'll just argue in opposite direction. Can you run faster than your car? Once you are sitting in a car, you actually you cannot surpass as when you run on the ground. Can you fly without existing machine like aeroplane or other thing? And can you swim as fast as the ship goes in the sea? So if you do open surgery, you see what are you doing? This is the open surgery. You are doing open surgery. And what are you using? You are using scissor. You are not cutting with the finger. So you're using anyway scissor. And same thing in the robotic. You are doing you are using scissor only, scissor or other thing or needle holder. So this argument doesn't hold that I can do same thing with my hand. Why should I use robot? So robot is actually they are your hand only, but they are better scissor, better needle holder, and better vision you have. And then there is no haptic touch sensation. Actually, this factor can be taken over by vision. Vision is so enhanced that you may not be feeling anything, but you don't go in the wrong plane, you don't cut the wrong thing. So it takes over, the vision takes over the touch sensation, and you can take the assistant's help. He can touch and with his suction and with his other thing like grasper and tell you what is this is hard or is the tumor or what is there. And in future, haptic sensation will come in the robotic surgery. That's what the technology is heading. But particularly, but personally, I feel we don't need it. I don't need it. And safety, any indication can be rectified while operating through the robot. However, in the beginning, sometime one may require to convert. I have in 1,000 of my surgery, I have converted only one patient to the open surgery because I injured one artery. We rectified that completion and we docked robot again, and then we continue the surgery with the robot. There's a misprint, there's a 10,000, there's a 1,000. Now the only problem with the robot is this. Imagine you have luxury car. You have luxury car. Don't imagine now. You have luxury car from the different brand like Audi, Mercedes, or Range Rover, whatever. There are so many different luxury car. But imagine you have only one brand, like Mercedes is on all over the world. What will happen? You know, that's what is happening in the robotic. We have only one company which is having this robotic machine. There is no other player in this field. So that is what the things are causing problem. These are some future of robotic surgery. The robot will be becoming a smaller size. They will be having rapid deployment, easier to use. You can put on the actually deployed on the this thing. Put on they are on the roof, and you just bring the table and start operating. Then you can have nursing robot. They can have the nurse, and they can even operate also. When you put some, you know, their software people are designing so that you can put the different you know, types of anatomy with the variation in anatomy and the steps to rectify that. This is going on. Then the new concept of OR, you are sitting outside the OR and operating. This is how the OR is inside, patient is inside, and you are actually operating from outside OR. There can be like operation home, going to the operation to the residence of the patient. You can go and operate there. This is another thing which can be work out in the in future. And these are the different kinds of robot used in the war, when you can put the whole of the operation theater on the robot itself, and they walk, go to the hospital and anywhere in the battlefield. So where do we exist in the robot today? The laparoscopy has learning curve. It has physical stress and compromising outcome, especially in the cancer in the beginning of the learning this type of surgery. Robot bridges the gap, and you can operate if you start doing robotic surgery, surgeon can operate till 80 years even, because it's hardly take any effort to operate when you are sitting on robot. Can replicate completely open surgery. As you do in open surgery, you can do same thing with the robot. There are some reports. It came in 2006. I have not come across recently. They say artificial intelligence, you can complete operation by robot can be done, and they actually put the 10,000 operation database, and they claimed that they will replace half of the surgeon of the world, which has not happened so far. You know, a movie named Life of Pi, which was completely computerized, and the line in that movie was so realistic that we thought this. I thought that particularly till I didn't know that it was real. But later on, I came to know this was not real. This was anywhere with the computer. So this is one thing which I always quote, that this a doctor who operated a child, and then he commented this thing, that this is modern medicine at its best. When Dr. Michael Irish, a pediatric surgeon at Blank's Children's Hospital in Des Moines, Iowa, following a removal of a mediastinal mass, which is actually in the chest, from a 5-day-old boy who was only 8 pounds, and he removed this with the robot using Da Vinci surgical system. Then he commented that this is the modern medicine at its best. Thanks a lot. This is what is from my side. You guys can ask me any question about robotic surgery or relation to any other you know aspect.
So we have few questions.
Okay, we have few questions. What? You close my this thing. It will come now. This one?
Where is that window?
Here. I can come there. Here, come. What do I do? Okay, tell me the question, I can answer. If they are listening me, or I can come there. Yes.
Is there a chance of infections because of the robotic arm?
I actually cleared in my presentation. There's less chance of infection, but you have to take. I agree that if you are not having properly trained staff, and they are not sterilizing properly, there are guidelines for those for sterilization of these arms, how to wash them. Then you can have infection. Otherwise, it's done day and night. Every day we do this surgery. There is no extra chance of infection at all. Rather, it is less. As I told you, when you do open surgery, the whole of the abdomen is opened up, or whole of the surgical field is exposed to the operation air and all, which is not there in robotic surgery.
Another question is, how popular is robotic surgeries in India, and what is its future? How popular is robotic surgery in India?
Okay.
And what is
In India, it's picking up. Problem in India is cost. I think first robot came in 2006 in Delhi, and it was in AIMS, and later on private sector have actually, I may not be correct, and there's maybe another robot which came in private but was not used at all. I think first it was used in another hospital, but in AIMS it was first used in AIMS, and then it came to private sector, and now we have around 28 robots in India. So what is the field of future of use in India? For this question, in India actually this has to come. It's already there, and it is increasing every day. Every day, every few months, you hear that the new robot has come there. We are also planning to have another robot. Right now, there are, if I'm not wrong, there are 28 robots in India so far, and this number is very good number looking at the country's economy and all. But this will go up since the the bigger hospitals are coming, the government sectors are becoming like anything. So this number, there's a in India it is must, and all the young surgeons, they will be going for this type of surgery to learn that, and then the patient demand is there on internet. They read everything. Most of the patients, they come to us, they already know that they have to have robotic surgery. So this is a patient demands also. If the patient is demanding, then you have to have this facility in your hospital.
Another question is from Jay G. He's asking, is robotic surgery safer than normal surgeries, and what is its success percentage?
Yes, it's absolutely safe. There's no doubt about this. You have seen my data per se. I have converted only one surgery to open. Otherwise, they have done very well. If it is not safe, it will not be popular. And when you even in the beginning of your this thing learning, beginning of your learning this technology, the surgery, they are absolutely safe. They are safer than the laparoscopic surgery. Laparoscopic surgery has one of the biggest disadvantage that if you don't you are not it takes long time in learning. While robotic surgery, the learning is very easy, is safe, you don't harm to the patient at all, and especially the complex surgery, which are most important when you do these complex surgery. When you switch over from open to robotic surgery, the learning is absolutely safe.
The next question is from Rasika Bhatt. The question is, what is the minimum expertise level required to train in robotic surgery?
Minimum expertise level, you can't say that this is these are the number of the patients when you will be perfect. No, it depends many times the surgeon itself. Many surgeons, they are fast learner. Many surgeons, they take time. But on an average, one has to do work in a high volume center. Like you have to do the particular type of surgery around 50 to 25 to 30 surgery per year in that particular field, in that particular operation. If you do 25 to 30 per year, this is taken as good volume, and the surgeons, they become expert. One can say after, in the beginning, many surgeons made that comment that after doing 300 radical prostatectomy, I feel that I have learned this surgery with the robot. So this particular number is not important. It's the surgeon's skill, and but then you do require good exposure to these surgery. It's not that you do only one or two. It's not like this. You have to do every day almost, or every month you have to do around 15 to 20 surgery if you can do, or at least 12 to 15 surgery, so that you can learn about you can perfect about the surgery. This one, you can put it here.
Patient of yours from Nepal wants to know about urorectal fistula repair.
Okay, this is done very easily with the robot. This is done with the very easily with the robot. Urethral fistula. This is rectoprostatic fistula. I think this is one of my patient is Nogzang Thapa, who had after HIFU, and it must be him only. And so this is very easily done with the robot, and because it's a place where robotic arm they go very easily. But if you see when you do these cases as open surgery, you do struggle, and sometimes you'll end up with a compromised outcome. So it's really good for these type of patients.
Another question from Rasika Bhatt is, when you talk about the cancer patients, so where robotic surgery is more feasible and improves outcomes?
In cancer patient, actually, it has a huge role, and especially when you do these complex surgery about like prostate, radical hysterectomy for C endometrium, or radical hysterectomy for cervix, RPLND. The cancer outcome is same as open surgery. I'm not saying this you give better outcome than the open surgery with the robot. It's not. Gold standard is open surgery. You can compare the robotic surgery with the open surgery in cancer outcome. But the robotic surgery, it takes over in less hospital stay, less pain, less blood loss, early recovery. These are the advantage with the robot. And if you are giving the equal cancer outcome, cancer control outcome as equal as open, then the robotic is better. This is how you actually take this technology.
Sarita Rajwal is asking, is there a center wherein doctors can learn robotic surgery?
Yeah, there are many centers in India. This is question from Sarita.
Yeah.
That is there any center in India? There are many centers in India. I learned here only. I did not go outside. I just did my training on pig for one day in America, and I came here. I called one of my friend who is head of the department of All India AIMS, and he for one surgery as a mentor, because I was doing these open surgery already for last 13, 14 years. So this was not a problem for another 15 years. So this was not a problem for me to learn immediately. And now the young surgeon who come, because they are not exposed to surgery also. So these they can at Rajiv Gandhi, at AIMS, at Medicity, in South also there are some centers. So they have to work in the department of those concerning specialty. So they can definitely learn easily in India.
Okay, we'll take one last question. That is from Pratigya Thapa. Man cannot depend totally on technology. So what are the chances for errors or faults?
I know this. She is the daughter of Nogzang Thapa. So her father had that small problem. He is all right now. No, I'm not saying you can 100% depend on technology. And this is not actually we are depending 100% on technology. The technology is working when my hands are working. Otherwise, it is not working. Suppose the technology stops working. There is some breakdown in the robot. You can immediately de-dock the robot and start open surgery, or you can use your laparoscopic skill. So it's not that we are 100% depending on the machine here. So thanks a lot, everybody, whoever logged in. This was about robot as a future of surgery, which is improving, which is actually percolating in society slowly. As the main reason is cost, and not every hospital can afford to have the robot. And if you want to make a successful robotic program, you have to have number of patients. Luckily, in Rajiv Gandhi, we have this situation, and we have finished almost more than now 1,300 surgery with the robot. So, but I think once it becomes cheaper, there are factors which hopefully will improve in future in the world market. I hope the more company they come with the different machines, which is the most important in any market, because if you have one player, they starts exploiting. So if that happens, is definitely the scene will be different all over the world. Thank you and bye-bye. Done?
Thank you, Dr. Rawal. That was really an insightful session. The recording of this webinar
Available on
will be made
80healthworld.com.
available on 80
We'll
Health.
keep you posted on the same. Thank you so much, everyone, for joining this
Thank you
webinar.
so much, everyone.
Yeah.